My name is Stavast. I'm the product manager for anesthesia Northwest Europe at Mindray. And in the upcoming few minutes, I would like to talk about the automatic controlled anesthesia and the green anesthesia without compromise. As we look at 2015, we saw that 266 million surgeries were performed in that year only. And as stated by Varghese and his colleagues in 2021, during a procedure using inhaled anesthetics, only about 5% of administered anesthesia is metabolized by the patient, and the remaining 95% is exhaled by the patient as waste anesthetic gas. These waste anesthetic gas are responsible for 35% of all emissions of a hospital. Most of the organic anesthetic gases remain for a very long time in the atmosphere, where they have the potential to act as greenhouse gases. Published atmospheric lifetimes range between 1.4 and 21.4 years for SIVO and desflurane, respectively. For nitrous oxide, it's even 114 years. A scavenging system draws the waste anesthetic gases out of the surgical field to minimize the staff exposure and vent these agents into the atmosphere and the outside air of local communities. Now, the impact of inhaled anesthetic agent over the overall global pollution of the environment has been known for more than a decade. Loew and Ernst, describing the closed system anesthesia practice they applied already in 1981, stated that the reduction of fluorocarbon emissions from operating rooms is an additional ecological benefit. Desflurane may have the greater potential of environmental impact than the other drugs. The greenhouse gas impact of desflurane is 15 times higher than of isoflurane and 20 times higher than of sevoflurane. And this on a Mach-hour base if applied in an O2 and air mixture. The fresh gas flow is the main determinant of the amount of waste gas released into the atmosphere. Therefore, we should focus on the amount of the fresh gas flow to reduce the environmental impact of waste gas anesthetic agents. In the last few years, we really started to feel the effect of the global warming seriously. And if the use of low-flow anesthesia is not limited to clinical studies and becomes more widespread all over the world, it's obvious that there will be an environmental gains as well as economic gains. The automatic controlled low-flow anesthesia is easy to use and might increase the low-flow anesthesia and minimal flow anesthesia by reducing concerns about oxygenation and the depth of anesthesia. In addition, less pollution of the operating room air is another benefit in terms of personal safety. Gauger et al. Stated that spontaneous abortion rates were increased in anesthetists who were exposed to waste gas more. A study done in 21 by Yusuf and Toprak, Kolak and Toprak, sorry, looking at feasibility, safety, and economic consequences of using minimal flow anesthesia with a machine, in this case, equipped with automatic gas control. Their conclusion was that using automatic low-flow anesthesia may reduce some concerns about hypoxia, the anesthetic depth of the operation, and increase the low-flow rate usage and provide an ease of use. They were able to maintain an FiO2 of 1.4% in patients undergoing hepatectomies without many setting changes, and we think that the AGC mode is better than manual adjustments in terms of ease of use. And later on, we will come back to this and we will see that if we look about the some of the thoughts about the ACA itself. Now it became evident that, and as we saw, that the reducing of the fresh gas flow rate will have the biggest impact on the reduction of the waste gas. Now, how to reduce this waste gas? First, of course, as said, reduce the fresh gas flow rate. Then to avoid accidental leakage into the OR and using a valid scavenging system. Now, to reduce the fresh gas flow rate, we have some features in our devices built in, like the optimizer function, the anesthetic agent prediction tool, the anesthetic agent measurement tool, and the ACA. And to avoid accidental leakage, we have flow pause and gas sampling return. And if you look at the anesthetic gas scavenging systems, we use an EAGSS system that's available for high flow, low vacuum and low flow, high vacuum. And we will come to this also later. Now, the first thing that we saw in reducing fresh gas flow rate was the optimizer. Now, what is the optimizer? The optimizer is a tool that indicates the optimal fresh gas flow rate, considering the leakage, the patient consumption, and the CO2 absorption. This is only a decision-making tool and advises the user how to optimally set the ideal fresh gas flow rate. The anesthetic agent prediction tool. So this is a tool that's available in our device if you're not like or want to use the automatic controlled anesthesia. This function will be available for you. And it looks at the past 10 minutes, then the current value, and the future trend in upcoming 20 minutes. We have the indication of the agent, the vaporizer settings. We see the fresh gas flow of the O2 percentage settings and the MAC values to the vaporizer settings. And this will better project the future state based on a trend vector of agent concentrations. We can better perceive the current state of drug delivery, the drug concentrations, and even predict the drug concentrations. And therefore, we can better adjust the vaporizer settings to the individual patient needs. The anesthetic agent measurement tool, well, this is not directly reducing the fresh gas flow rate, of course, but what we saw by indicating the output of the severain or desferrane vaporizer in milliliters per hour, plus the indication of the cost involved in such, we see that the users are tending to go low with the flow much quicker by seeing this, say, like a high price that they are using currently, and they want to drop this as soon as possible. So this is seen in the habit of people using this. Of course, it does not reduce the fresh gas flow directly, but it says, of course, the agent usage speed and cost, and at the end of the case, we see the agent and gas consumption. The ACA combines, of course, everything on its own. It's an automatic controlled anesthesia. It automatically adjusts the fresh gas and vaporizer output to quickly achieve the preset target and end tidal agent and inspiratory oxygen concentration. It will do this as fast as possible, and that within 120 seconds. It will perform low flow anesthesia to balance the patient safety and economic cost. The lowest set rate will be 300 milliliters per minute. And of course, looking at the uptake rate of a normal steady state patient, about 350 milliliters per minute of oxygen. This is of course, an ideal setting clinically, so not go below this. So therefore, we choose the 300 milliliters per minute as the lowest flow possible. And of course, you can always choose for a higher flow if you want so. So it will go up with the flow as high as possible to achieve the targets, inspiratory for the O2 and expiratory for the anesthetic agent, as fast as possible. And as it's received, then it will reduce. And then it will reduce no lower than the flow that you want to set there. It could be 1 liter or 2 liters according to your issues. The automatic controlled anesthesia gives you a more stable anesthesia depth plus oxygenation. We saw that by the time of the end-tidal anesthetic agent concentration maintained in the desired range, that increase in the study by 30%, that it's more in the desired range than according to the manual settings. And we could reduce the agent consumption and greenhouse emission if you compare again manual according to the automatic controlled anesthesia, and we could decrease the agent uses between 35 and 45%. And of course, it's also easier for the workload because less adjustment for fresh gas and vaporizer settings that will extremely reduce the workload. And we saw that adjustment times that change for 6.9, so nearly 7 times, reduced to 1.6 times that we adjusted the settings. So it will really optimize the workflow of the anesthetist, and we can really concentrate more on our patients. And the ACA is really easy to use. By tapping on the gas settings, the menu will pop up, and here you can choose for the ACA mode, then set your desired inspiratory oxygen target, your end-tidal target for anesthetic agents, and confirm it by pushing on the green button. Then the wash-in period will start. You will see the settings of your vaporizer. You will see the settings of your tidals, of your targets of end-tidal, SIVO or death frame, whatever you choose. Then you see the trends, so you see where it works. You see your inspiration O2 targets big, and also your minimal flow settings. So here you can see exactly how the wash-in takes place and how it maintains and how stable it is. By the end of the operation, you can go into this menu again, and then you can set either your vaporizer to 0, so it will close the vaporizer, but it will coast off very slowly. Or you can go to the purge flow rate and set this purge flow to the desired flow rate. So that could be 10 liters, but also up to 15 liters. And then you say purge. Then it will show in the gas menu on your display that it's purging. And here you can then really quick get rid of the anesthetic agent into the system. If you're looking at the operating room and to avoid accidental leakage, there we have the flow pause function. The flow pause function will stop fresh gas and the ventilation temporarily, but also the alarming will stop. It prevents unnecessary leaks of anesthetic gases during intubation, suction, but also repositioning, of course. Every time when you want to disconnect the patient from the anesthesia device, so that no gases will run into the operating room, this flow pause can be activated. And it will be activated for 1 minute, and you can twice, say like a maximum of 30 seconds more. So it's a maximum of 2 minutes. And as soon as you're done, you can just set end flow pause. If you only use this 1 minute and you don't do anything, after 1 minute will automatically start the ventilation again, the alarms will become active, and all the gases and anesthetic agents will flow again. This can also very good be used for thoracic surgery, for instance, if you want to do the sternotomy, use this function during the sternotomy phase. And it's very, very easy to use. The sample gas return, the sample gas from the gas module will be recycled back into the breathing system. So you can put it out into the waste gas system, but also into the breathing system again. So if you were using really minimal flow anesthesia, this is a very, very neat thing to do. So you don't have any problems. We also talked about the usage of valid scavenging systems, and we have a system called the EAGSS, the electronic anesthetic gas scavenging system. And what's so special about that? Well, it's because it's completely electronic. During the pre-use system check, the AGSS is checked automatically. So you don't have to do anything about that. It will be done automatically, and it will see if everything's working, if the flows are in the correct range, yes or no. During the surgery, the scavenging flows are continuously monitored. So as soon as any abnormality is being seen, you will have the information directly on your status screen of your on the device to inform you that something is not correct or not. At the end of the case, and this is also where it's different, at the end of the case, if you go to standby, it will automatically disconnect from the hospital vacuum system to reduce energy consumption by closing an active valve in the EGSS system. So this will completely close off. So there's always the well-known hissing that we hear the whole night in the operating theaters, although nobody's working there, it will vanish because it will automatically cuts the system off, and there's no energy expenditure for the hospital. So this is a very, very neat feature. Now, looking at sustainability and the ecological footprint, there are many healthcare institutions, and we saw this especially in the Nordics, also the UK, Benelux. This is becoming more and more important, and not only there in those countries, of course, we see that globally throughout. But here they are really choosing their preferred medical industry partners already based on their efforts of reducing the CO2 footprint and the integrating processes to reach a higher level of sustainability. The ESA have recently launched actually a dedicated committee looking at sustainability and the ecological footprint, and it's presided by Dr. Patricio Gonzalez from Madrid, La Paz. And one of their goals is to more and more promote and do research for different ways to reduce the ecological footprint. And a hot topic is the initiative, of course, of zero emission anesthesia. And zero emission anesthesia actually is the practice to prevent any anesthetic agent release into the atmosphere during the anesthesia procedure. So this can be done by filtering the anesthesia waste gas, capturing the anesthesia waste gas, or breaking down the components of the gas. Now, the best way to do it, and we saw that before already, is of course by reducing fresh gas flow initially already. So a very high part of the exhaled gas are going to be rebreathed. So we really have very, very less gas going into the waste gas system because we're not overflowing the system. But the few gases that are coming into the waste gas system that has to be vented out, or during the end of the operation, of course, that can be filtered. Now, old techniques using active carbon filters have been used for many years, but also have proven not always to be that effective. Dentists and veterinarians are using it still today. Now, newer methods are now being developed and is looking to capture the gas and recycle it. Now, of course, being developed, they are already developed, but they are going to develop in a more and more industrial standard so we can easier adapt it to our devices. And to capture this anesthetic agent is the preferred method on the anesthetic devices today. And companies like Zeusys Medical and SageTech Medical are there very, very active in providing systems to do so. So in conclusion is that our goal is to minimize anesthetic gas emissions from the beginning to the end of the perioperative journey without compromising the safety for the patient, environment, and the healthcare professional. And by the way, did you know that using Desfrain for 1 hour is equivalent to 470 miles of driving if you combine this technique with the use of nitrous oxide? Just for you to know. A9 anesthesia system, we all round environmental safety without compromise. Thank you for joining me in this short short speech about the ACA and the greenhouse effects. And I wish you all a very, very nice Congress. Thank you. Bye.